You may have heard stories of mountain climbers and other thrill seekers who get caught unaware with the cold and end up with limbs falling off, although you may be shocked to understand that this isn't always the case. Frostbite is one of three main cold injuries, alongside non-tissue freezing injury, or trench foot as it is more commonly known, and hypothermia, all of which can pose dangerous or even lethal health risks. Frostbite occurs when ice crystals form in temperatures of below -2 to -4 degrees Celsius and the skin or deeper tissues freeze. The areas most commonly affected by frostbite include the extremities, cheeks, ears and nose, and it is measured in degrees depending on the severity and change within the tissue. First degree frostbite refers to superficial damage to surface skin cells that isn't permanent, and the primary symptoms include numbness and redness. In the second degree, blisters develop initially and the skin hardens. This hardened skin dries in the weeks following exposure, blackens and peels, and as a result, potential long-term damage may include cold sensitivity and numbness. During third degree frostbite, the subcutaneous tissue begins to freeze, promoting the formation of blood blisters and discoloration of the skin. After the injury, there is continuous pain and a black crust of necrotized tissue called eschar forms, which is also present in severe burns, gangrene, ulcers and necrotizing infections. In extreme cases, an escharotomy may be needed to restore blood and lymphatic circulation. There may also be long-term ulceration or damage to growth plates, which is the cartilage found between the end and shaft of bones where the bone grows longer. Fourth degree frostbite is the most severe form of frostbite in which structures like muscles, tendons or bone are affected. In this case, symptoms include colourless skin, lack of pain during rewarming, and a rigid texture. The skin becomes black and mummified, though the extent of the permanent damage can only be determined after around a month, with auto-amputation potentially occurring after 2 months. Next, let's talk about the process of how frostbite occurs. Firstly, there is the freezing stage, which creates issues with the circulation, direct freezing of tissues, and ice crystal formation within the tissue. Problems with circulation arise as the blood vessels constrict to divert more blood to maintain the core body temperature and perfusion to the vital organs, which may include ischemia and cause the area to die. This is called gangrene. Initially, a state of alternating vasoconstriction and vasodilation may occur to preserve function in the extremities, though eventually the vessels will remain constricted. Injury to the endothelial linings of the blood vessels causes inflammatory markers to be released and clots to form, which may lead to thrombosis, in which these blood clots block the blood supply to certain areas, causing ischemia and subsequent cell death. A thrombus may also cause a stroke, heart attack, or pulmonary embolism after vasoconstriction, as it increases blood pressure, which is a well-known risk factor for all of these conditions. The direct freezing of tissues can cause cell death in itself, and also increases blood viscosity, causing an increased risk of thrombosis. The ice crystals which subsequently form directly damage cell membranes, which are primarily composed of water and lipids. They also cause dehydration, which promotes cell death and may damage small blood vessels. Not only does freezing pose problems, but the excruciating process of rewarming can be harmful in itself. Firstly, it may cause reperfusion injury, which includes edema, vasodilation, severe inflammation and reduced blood flow. Platelet aggregation may also occur in response to endothelial cell injury, which makes thrombosis and ischemia more likely. If someone attempts to rewarm areas of the body that are likely to freeze again, this will be extremely harmful as the thaw-refreeze cycle can cause significant damage. On the other hand, it is more effective to rewarm the area quickly rather than a gradual increase in temperature, and this should be to around 40 to 42 degrees Celsius to retain optimum tissue function. In terms of the risk factors for frostbite, the first is exposure to cold, which may be more of a problem for the homeless, those who live in cold climates, or people who can't adequately protect themselves from the cold, such as the young, elderly, or intellectually disabled. Other risk factors are those which cause circulation issues, such as jewelry or clothes, conditions such as diabetes or Raynaud's phenomenon, and smoking and alcohol, which increase blood pressure and thus decrease the existing blood supply to the extremities. After rewarming, treatment includes debridement of damaged tissue, pain medications, and infection-fighting drugs, as the skin becomes exposed and at increased risk of infection. Both continuous wound care and protection are essential, and depending on the extent of the injury, physiotherapy and rehabilitation may be necessary. The second type of cold injury is trench foot, which may be misleading as it does not require freezing conditions, rather prolonged exposure to damp conditions of up to 16 degrees Celsius. These unsanitary conditions cause damage to the capillaries, thus reducing the blood supply to the area and causing tissue deterioration and death. resulting in similar symptoms to frostbite. Despite this, it is easily prevented by keeping extremities clean, warm and dry, and not wearing tight-fitting clothing. The treatment for trench foot is mostly similar to frostbite through rewarming and dressing, and long-term damage is likely. The last and most severe type of cold injury is hypothermia, which is regarded as a medical emergency in which the body's core temperature drops to below 35 degrees Celsius. This occurs when heat production is lower than the rate of heat loss. Heat production occurs in the muscle tissue such as the heart and liver, while 90% of heat loss is through the skin and 10% through the lungs. Increased muscle contractions, as seen in shivering and exercise, can increase heat production many times over. Two things can cause hypothermia, the first of which and the most obvious is exposure to the extreme cold. Immersion in cold water induces heat loss at a rate far higher than in air, which is why hypothermia is so prevalent in people who've fallen into freezing lakes or the sea. As this happens, the sympathetic nervous system becomes excited, employing multiple mechanisms to increase body temperature, such as shivering, hypertension, tachycardia, faster respiratory rate, and vasoconstriction of peripheral vessels. Hypoglycemia may also be present as more glucose circulates in the blood due to decreased insulin production and glucose uptake by cells. The second cause of hypothermia is substances or conditions that deplete heat production or increase heat loss. These include substance abuse, alcohol intoxication, and hypoglycemia, which may be caused by kidney or liver conditions, or more commonly through diabetic medications or eating disorders like anorexia. As the core body temperature continues to decrease, heart rate, respiratory rate, and blood pressure all decrease, leading to confusion, amnesia, loss of fine motor skills, and eventually myocardial infarction. Mild hypothermia is described as a core temperature of 32 to 35 degrees Celsius, in which the person is usually awake and shivering. The treatment for this involves passive rewarming, in which the person is placed in a warm surrounding environment where their own body can be encouraged to increase its temperature. In moderate hypothermia at around 28 to 32 degrees Celsius, the person will show signs of confusion and shivering will begin to stop. To treat this, active external rewarming will be employed, which uses warming devices like heating blankets or hot water bottles to actively increase body temperature without invasive techniques. In severe hypothermia, there is a core temperature of around 20 to 28 degrees Celsius or far less, and the person is likely to be unconscious and displaying limited or no vital signs. Treatment includes active internal rewarming, where rewarming could occur inside the body. This may be through IV warm fluids, irrigation of body cavities with warm fluids, or warm inhaled air through heart-lung machines or extracorporeal membrane oxygenation or ECMO, which is essentially a more long-term mechanism of cardiopulmonary bypass. The elderly are more at risk to hypothermia, as detection to changes in temperature is less sensitive due to a decreased number of nerve endings, they contain less fat for insulation, and they have a lower metabolic rate, meaning it is more difficult to generate heat. Alcohol may also impair detection systems as it reduces judgment and causes vasodilation. This induces a warm sensation despite increased heat loss from the extremities, and also slows down metabolism and thus heat generation. Even though it may appear that hypothermia can only be harmful, believe it or not, it can also be used therapeutically or even surgically. The first way this can be done is through targeted temperature management, which is principally used to reduce the harmful outcomes of reduced blood supply to the brain after resuscitation, as seen in comatose cardiac arrest or stroke survivors. The temperatures used usually range from 32 to 36 degrees Celsius, and there are many mechanisms of how this process can be so useful. The main one of these is that there is reduced cerebral metabolism by approximately 7% per 1 degree Celsius temperature decrease, as the cold temperature reduces both glucose and oxygen uptake. There is also cerebral vasoconstriction to reduce intracranial pressure, and increased vascular permeability results in lower rates of edema formation. Along with this, the inhibition of caspase activation leads to less programmed cell death and reduced inflammatory responses during reperfusion, which may lead to an increased ICP. Placing the patient in a hypothermic state also decreases free radical formation, which is associated with a wide range of diseases as occurs in reperfusion injury. In general, the side effects of targeted temperature management are mild, though without proper management, the chances of severe damage are significantly increased. The first of these is reduced cardiac output, along with higher instances of infections like pneumonia. There is a greater than 50% chance of pneumonia in patients undergoing TTM for more than 7 days due to decreased immune system function. Along with this, there may be increased insulin resistance and reduced insulin release, therefore insulin infusions are necessary to control hyperglycemia. Increased production of lactate, glycerol, and free fatty acids may occur, which could lead to metabolic acidosis. Prokinetics may be needed due to decreased gastrointestinal motility, and other abdominal issues may include diuresis and electrolyte disturbance in the renal system. This is due to decreased reabsorption of solutes into the blood in the ascending loop of Henle, a part of the nephrons in the kidneys. Circulatory issues may persist as gases become less soluble in bodily fluids such as blood as the body temperature decreases. Finally, there is a greater risk of bleeding due to the reduced number and function of platelets. This means that therapeutic hypothermia can be harmful in multi-trauma patients, especially as sacrificing other parts of the body in favour of neuroprotection is controversial. In terms of the methods of how patients can undergo TTM, the first of these is directly into the body via cooling catheters. An IV line is inserted into the femoral vein and cooled saline solution is circulated to reduce the temperature of the blood. This usually cools the body at a rate of 1.5 to 2 degrees Celsius per hour to a temperature within 0.1 degrees Celsius of the target level. In this manner, the doctor can steadily increase the temperature when required to avoid harmful rises in intracranial pressure. The second, more indirect method of cooling involves ice packs or cooling blankets. Around 70% of the person's surface area is covered in blankets which circulate cold water to reduce skin temperature, without the use of invasive techniques. However, this method can be prone to leaking, has a lower induction time, and may cause skin burns to some patients. Apart from targeted temperature management, hypothermia can also be used during surgery. In this way, deep hypothermia is induced at a temperature between 15 to 25 degrees Celsius and causes arrest of circulation and brain function. This preserves organ function while the circulation is stopped, although the patient can undergo cardiopulmonary bypass if perfusion is necessary to other organs. On the other hand, if the surgery requires it, then complete circulatory arrest can be achieved. The process of deep hypothermic circulatory arrest is used for delicate operations on the brain, which involves a lack of blood flow, such as repairing cerebral aneurysms, atriovenous malformations, thrombectomies, or vascular surgery and repairs to vessels of the head, neck, or aorta. However, the risk of brain injury increases after the person has been in this state for longer than 30 minutes, though circulatory arrest for up to 60 minutes is possible, though not preferred, as these patients will almost always suffer irreversible brain damage. So, while hypothermia in many cases can be life-threatening, it is also a critical practice that can preserve neurological function and turn one of nature's most terrifying extremes into a surgical tool that thousands of cardiothoracic and neurosurgeons have in their arsenal.